Hi guys, my name is Amanda, and I'm going to be talking about the book called Safe Patient, Smart Hospital by Peter Pronovost and Eric Lohr. Let's first talk about what this book is about. This book is about Dr. Pronovost, who is currently a physician at Johns Hopkins University Hospital down in Baltimore, Maryland, and how he's dedicated his entire career to increasing patient safety within hospitals, not only at Johns Hopkins but throughout the entire country. He was motivated to take this pathway based off of a patient called Josie King. Josie King is a toddler who unfortunately suffered severe burns throughout her entire body, who ended up in the pediatric ICU at Johns Hopkins. Her mother, Sorrel, noticed that Josie was declining while she was in the pediatric ICU and tried voicing her concerns to staff. And unfortunately, staff kept telling her Josie's mom, Sorrel, that Josie was fine and she was just recovering and that all the tests and lab results looked fine. And unfortunately, Josie ended up dying due to dehydration. And by the time staff noticed that Josie was in fact declining, it was too late. So our first concept that we're going to take away from this book is teamwork among a unit. Dr. Pronovost talks throughout the entire book about how important teamwork is on a unit and how that increases patient safety and satisfaction. He feels that in order for the patient to have the best level of care provided, that the teamwork on the unit needs to be strong. He says the desired output a unit should have is having that increased patient safety. He develops a checklist that focuses on communication and culture within the hospital, and he feels that in order for the patient to be to have the most patient safety and to be the most satisfied, that the communication and culture among that unit needs to be strong. I am calling the organization that he's trying to focus on creating within a hospital a conversational organization. Schumann, Slaughter, and Williamson, which is one of our textbooks, describes in chapter 1 what a conversational organization is. They say that this type of organization has no leader. It has workers who all have an input. There's a desired output, but the pathway to reach that output is very flexible. This can relate to Dr. Pronovost in this book because Dr. Pronovost has a desired output, which is patient safety, increasing patient safety, and he includes all the workers within a hospital and within a unit to help gear how to increase that patient safety. When he develops this checklist, he's always asking for people's opinions and inputs on how to make this checklist better. He also describes the barriers that he faced when he was creating this checklist and the barriers that exist to preventing teamwork from being present among a unit, and he talks about the ways to overcome those barriers. Therefore, by acknowledging the barriers and acknowledging the setbacks, I feel that this flexible way of that organization has flexibility because they can see their barriers, but they're flexible on how to get around them. So how does improving teamwork change today's healthcare? Well, I found an article by Kelly and Ferrone that found that patients have multiple options on where they can receive care nowadays. There's tons of hospitals and tons of different organizations that exist, but they wanted to focus on why does a patient choose that facility to receive their care. They found that a patient chooses their facility based off of prior experiences, so if they've had a good experience in the past, where they've heard good comments from other people. So if someone else had good care at a hospital, that's where they're going to go, or based off of the hospital's reputation. They focused on the emergency department specifically, and they found that patients were satisfied with their care when they felt safe within the facility and when the workers worked as a team. They also found that a hospital care is very circular formation. This means that when the medical staff is happy and work together as a team, that increases patient satisfaction and patient safety. And therefore, when the patients are satisfied and the patients are happy, the staff becomes happy because they're not being yelled at or they're not being criticized by patients, and it creates a happy work environment. So therefore, it goes back to the beginning about how the happy work environment and the staff being satisfied would go back to influence patient safety and patient satisfaction. This article and Dr. Pronovis found that in order to increase patient satisfaction, the staff need to work together as a team. And like I said earlier, the article focuses on the emergency department, whereas Dr. Pronovis, as I said earlier, focuses on the intensive care units. This can be a significant difference only because of the different settings. The emergency department, you have a higher nurse-to-patient ratio. Because this ratio is higher, the patients aren't seeing their nurses as often. The nurses are spreading their care among different patients, so the care that they're providing to the patients might not be as long as a nurse in the ICU who only has 2 or maybe even 1 patient, so they can focus all their care on only those patients. Depending on the criticalness of a patient down in the emergency department, 1 patient might get all the nurses' attention and the other 3 might get none, because if a patient is very critical, that nurse isn't able to leave their side. The pace is also different. The emergency department is very fast-paced as opposed to the ICU, where in the morning they're very fast-paced, and if a patient starts declining, then it can become fast-paced, but usually the ICU is slower paced. Most of the patients in the ICU are intubated, unlike the emergency department. Because they're intubated, the patients don't necessarily remember the care that they're provided. That's more of a patient's family noticing the care that's being provided to them. And the length of time differs. Emergency department, the patients are only there for a couple of hours, hopefully. And as opposed to the ICU, where the patient could be there for days, weeks, even months. I also found an article by Widener, Smith, Storer, and Young, which focused on patient safety within a hospital. I felt this was important because Dr. Pronovis is talking about patient safety, and so is this article. This article found that teamwork among a unit was a very strong dimension of patient care, and both the article and Dr. Pronovis focused on where improvement needs to be made in order to increase that patient satisfaction. So how do the teamwork that's on a unit need to be improved? Dr. Pronovis, like I said before, came up with a solution in order to improve this patient satisfaction or patient safety and teamwork. And Widener and colleagues didn't really come up with any kind of solution. They just compared the United States care in a hospital to other hospitals in other countries. They wanted to see, how does the United States differ than other countries, and how can the United States learn from the other countries and how they provide care to the patients. But this article did find that teamwork was very strong among a unit. They found that staff was very satisfied with how the teamwork was and their input, and they felt that teamwork was strong and didn't need much improvement. However, Dr. Pronovis felt that the teamwork among the unit was very weak and it had a large area of growth that could occur. So the takeaway message on how teamwork affects today's healthcare is the better teamwork dynamic on a unit, the better safety the better safety there is for a patient, and patient satisfaction will increase. And when teamwork exists on a unit, not only is the patient satisfied, but also the staff is satisfied. And the staff satisfaction can influence patient satisfaction, because if both are satisfied, if the staff's satisfied, then they're going to portray a happier environment, and the patient will also be satisfied. So our next concept is communication among staff. Our textbook, Boutrous and Purdy, discussed the importance of communication and felt that open communication and participative decision making is key to making improvements among communication. As you can see on the slide, I defined participative decision making, and the definition involves all members to give their point of view, and all suggestions are considered when making a decision. Dr. Pronovis also focuses on improving communication within a unit. As stated before, Josie King, communication was not very strong in this case. This was his inspiration on why communication does need to improve. If Josie's mom, Sorrel, was heard by nursing staff, they could have been able to relay their concerns to the residents who would go to the attendings. However, by the time Sorrel could convince the nursing staff that something was wrong with Josie, and by the time the nursing staff was able to convince the residents, it was too late by the time the attendings came down to see Josie. So by improving the communication, teaching staff that it's important to listen to the family members who are at the bedside, this could potentially save patients in the future. And personal example on how I've seen poor communication is I work in the emergency department, and as I've stated before, it's very fast-paced. I saw a nurse who was taking care of a patient who came in with shortness of breath. The patient was evaluated by the nurse and the physician told the patient what they were going to order and what tests were going to be done. The nurse saw that the patient was declining, oxygen saturations were declining. Patient was really becoming fatigued from trying to breathe so fast paced, and the patient just was not looking good. The nurse went up and told the physician, but didn't tell the physician, details on how the patient looked. Kind of just said, hey, the patient's declining, what do you want to do? And the physician just ordered a breathing treatment. By the time the physician got back into the room, because they weren't told the severity of how the patient was declining, the patient had to be intubated. So now you just take a patient who was here for shortness of breath, who could potentially have gone home because all they had was pneumonia. The patient now ended up being intubated and having to be admitted to the intensive care unit, just because of this poor communication between staff. Luckily, this didn't end in patient death like the Josie King story did, but this still is a situation that the patient's outcome could have been prevented. So that's kind of an example on how we can influence today's healthcare, but we're going to go a little deeper. So I found an article by Starmer and colleagues which focused on the patient care handoff. A care handoff is when a nursing staff or a physician staff is done and they're transferring care to another physician or another nursing staff. They wanted to see how this communication process affected patient care. They found that medical errors were high because the handoff process wasn't being done correctly. So they came up with a solution. They standardized this communication. So they kind of came up with this checklist, if you want to call it, on what information needed to be relayed between the staff members at change of shift or change of handoff. This information included important lab tests, anything that the patient said, anything critical about the patients, something that if it's left out, it could influence patient care. They found that by the time this standardized communication was implemented, medical errors decreased and that information wasn't being lost in between change of shifts. Dr. Pronovost also focused on this down at Johns Hopkins. Dr. Pronovost, as I stated before, came up with a checklist that improved handoff so miscommunication wasn't occurring, and medical errors improved both in Johns Hopkins but also in the facility where Starmer implemented their checklist. The difference between Dr. Pronovost and Starmer and colleagues is that Starmer and colleagues kind of made a generalized checklist that could be implemented throughout the entire hospital, as opposed to Dr. Pronovost, who created a checklist that was only implemented in the intensive care units. The overall takeaway message is that miscommunication or lack of communication can have a negative impact on patient care, and when important information isn't relayed, it can endanger the patient and even cause death. And that when miscommunication causes medical errors, patient care is compromised and can even lead to death. And by increasing communication, less medical errors are occurring and patient safety is increased. So our last topic that we're going to talk about is how the patient needs to be number one. Dr. Pronovost talks constantly about how the patient is the main focus and everything we do within the hospital is to be focused around the patient. This type of care is called patient-centered care. We learned about this in our textbook. Schumann, Sloiter, and Williamson talk about this. The importance of patient-centered care is that patient safety is being addressed. You need to have your teamwork. Teamwork is a huge part of patient-centered care, and therefore the patient can have a positive care or a positive outcome, not necessarily a negative outcome. No teamwork can lead to a negative patient outcome. Communication needs to be strong between both physicians and nursing staff, but also nurses to nursing staff. And lack of communication with all members being involved. So therefore, patient-centered, you need teamwork, you need positive communication between all staff, and you need to have everyone be able to put in input. In order for the patient to have the best type of medical treatment is that all medical staff is giving input, not just the physician. As stated before, Schumann, Slaughter, and Williamson talk about this. They also talk about doctor-centered care. This is when the physician makes all the decisions and they have poor bedside manner. Before Dr. Pronovost implemented his checklist among the intensive care units at Johns Hopkins, he found that doctor-centered care is what existed before patient-centered care came on. He found that physicians were making all the decisions on the intensive care units, and that the nurses were just completing the tasks that were ordered, and that physicians weren't consulting the nursing staff about the patients. The nurses are the ones who are at the bedside the most and can see the patient and can hear what the patient wants to vocalize, and it's important that that nurse can then go to the physician and express those inputs, and that the physician takes those into consideration, and that was not being done in doctor-centered care. Nowadays, since Dr. Pronovost implemented his checklist and hospitals are doing evidence-based practice and things like that, patient-centered care is the most common type of care that you'll find within a hospital. And as stated before, this just allows multiple groups to participate in the decision-making process, and therefore the best choice is being made in regards to the patient care. I found an article by, I'm going to butcher these names and I'm sorry, Al-Zarani, Farhat, and Zolali, and they researched looking into a medical facility in Saudi Arabia. It was a United States military-based hospital, and they found that they wanted to look there about specifically infection rates. Saudi Arabia, being on a military base, has high risk of infection rates because they're not as sterile as a hospital here is, and they wanted to see how they were addressing infection rates. They found that the staff was all knowledgeable on how to decrease these infection rates, however they weren't following the protocols in order to do that. They found that physicians were cutting corners and weren't following the proper protocols and procedures prior to a procedure or prior to patient treatment. I found it interesting because Dr. Pronovost also talked about how physicians cut corners in the intensive care unit within Johns Hopkins. He found that if a physician was doing a procedure and he needed a certain type of equipment and it wasn't readily accessible, he would kind of just bypass that. Or he would become unsterile to go get that equipment and come back and never become sterile again. So here are people who have spent their entire career being taught how important infection rates are and how important procedures are, and they are cutting corners in order just to get the task done. Al-Zarani and colleagues found that when the staff knew a patient had bloodborne pathogen, which is, a bacteria or an infection, when they already knew the infection or bacteria existed, then they followed protocols. However, otherwise they weren't following protocols universally. So this is just how that article tied into the book. So I found that very interesting, that these high physicians who were supposed to have the patient's best care in mind were cutting corners and putting a patient at risk in order to just get a task done in a timely manner, as opposed to thinking about the patient and thinking about the care that was being provided to the patient. So this ties into how it impacts today's healthcare. I found an article by Dr. Kaiser, Gauntz, and Associates, who researched the communications between physician and nursing staff. As stated before, communication is very important, but especially between the physician and nursing staff. These are the people who are one-on-one with the patients most of the time, and these two need to be able to communicate in order to provide the best patient care. Dr. Pronovost found this in his book as well. He found that in the ICU, as stated before, the physicians weren't consulting the nursing staff, and that the care was only being decided upon or influenced by the physician's decision. And that, especially in the intensive care unit where a patient is critical, they need the best possible care. Both the article and Dr. Pronovost found that staff was not satisfied with communication. The physicians were satisfied, but not the nursing staff. Dr. Pronovost implemented his CUSP theory, which is a theory that worked on communication, the checklist, as I stated before, and he found that once this was implemented, the communication between the nursing staff and the physicians improved. I also found an article by Tak, Runkin, and Shi, which focused on physician communication and how the physician not only communicated with nursing staff, but also with the patient. And they found that when the patient feels that the physician provided well-rounded care, then they're satisfied. However, if they feel that the physician doesn't explain anything, they're not satisfied. And they also found that if a patient stated that they felt their voices or concerns weren't heard by a physician, they were not satisfied with the care. And they also found that they wanted a well-rounded care. And it was found that the best way to provide well-rounded care was when the physicians interacted with the nursing staff and involved them and the other staff members and treatment team and family members of the patient with the decision-making process. And therefore, the takeaway message is the more input and the more different perspectives, the best medical care is being provided. So that is all I have. I hope you enjoyed this. I'm sorry if I butchered any of these names. I have listed all my references, and I hope you enjoy my presentation. Thank you.